Yes, I'm Gillian Whitfield. I treat brain and spine tumours, so-called central nervous system tumours, in adults and children, and that's all that I do, so I specialise in that. And in adults, that means that I give radiotherapy and chemotherapy, but in children, my paediatric oncology colleagues, so that's my colleagues at Royal Manchester Children's Hospital, do the chemotherapy, and I do the radiotherapy for those children. I also spend some time on radiotherapy-related research, and in fact the Brain Tumour Charity part funds a trial that I run in adults. So I'm going to talk about radiotherapy for children's brain and spinal tumours, and hopefully it will demystify things a bit, but I'm sure there'll be questions, and hopefully I've left time at the end for those questions. Okay. So firstly, I just wanted, by way of introduction, to say a little bit about how common, or actually uncommon, brain and spinal tumours are in children. So in the UK, the commonest childhood cancer is leukemia, and the category of brain and spinal tumours as a whole is the second commonest, and it makes up about a quarter of all children's tumours. Overall, there are about 400 new cases a year of brain and spinal tumours in children, so it's actually relatively rare, and in a centre the size of Manchester, that would mean about 20 new cases a year. Also, just to say a little bit about the different types of tumour, and you might have had some of this in the previous talks, but the biggest category there is astrocytomas, and this is a mixed category, and they go from grades 1 through to grade 4. And grade 1 is quite a common tumour in children. One type called pilocytic astrocytoma that some of you might have come across is a grade 1 astrocytoma. But they go through grades 2, 3 and 4, and grade 4 astrocytoma is almost always what's called glioblastoma, which actually, if we were talking about adults, would be the commonest adult brain tumour, but in kids it's quite unusual. The second biggest category in red there is the so-called embryonal tumours. So they're called that because they're tumours that under the microscope are made up of a primitive cell type that looks a bit like a cell in an embryo. The most common type in that category is the medulloblastoma, which again some of you I'm sure will have come across because it makes up a quarter of all the children's brain tumours. And medulloblastoma is a tumour which arises at the back of the brain. When that tumour type or a similar tumour type arises in other parts of the brain, it's called PNET, or primitive neuroectodermal tumour. And then the third biggest category the second biggest was in purple there. The third biggest category there in, no, am I getting it right? Third biggest is in the green there, 10%, is ependymoma, which is mostly ependymomas and a few rare tumours called choroid plexus tumours. So these tumours, ependymomas, are tumours arising from the linings of the fluid-filled cavities in the brain, and most often in children they arise at the back of the brain, but they can arise in other parts of the brain and even down the spine. So radiotherapy actually has a role in all of these tumours. In some of these tumours it's always needed, and in other tumours it might be needed depending on the situation and in combination often with other treatments. So I just also wanted to mention a sort of common misconception that grade 4 tumours necessarily have a worse outlook than grade 3, 2, 1 tumours. And that can be true, but it's not necessarily the case. So the grade really means more about how the tumour would behave if it was untreated. And actually, for example, medulloblastoma, which is a grade 4 tumour, is one of the most curable tumours in children. Okay, now I struggle to see the slides. Okay, so yes, I wanted to say a little bit about why we use radiotherapy. So most children with a brain tumour will have surgery, and that's an important part of their treatment. But actually radiotherapy is second only to surgery in its potential to cure tumours. So a lot of people often think that chemotherapy must be the next most important thing, but actually radiotherapy has a vital role in curing tumours. If we look over the last several decades, survival in children with brain tumours has improved quite dramatically since the 1970s. Decade by decade, the situation has improved, not for every tumour type, it has to be said, but for most of the tumour types. And today, while there's a lot of hype about proton treatment, it's often forgotten that conventional radiotherapy, the type of radiotherapy we give at home in the UK, has actually also evolved enormously over the last 10 to 20 years, and it really is a state-of-the-art treatment now, and that's been made possible through improved imaging, improved MRI scanning, and the fact that, simply the power of computing. So computerized treatment planning means that now we can do a much more sophisticated treatment than we could do even 5 and 10 years ago. And that enables us to be more precise in how we target the tumour and how we spare nearby normal tissues, that are responsible potentially for late side effects of treatment. I'm not complacent in saying that. We still need to do better, and we're still exploring how we can do better in tumour types, but certainly treatment now is much more sophisticated than it used to be. So a little bit about how radiotherapy works. Radiotherapy works in a very, very specific way. So it doesn't work by generally sort of heating the brain or frying the brain. It works very specifically by interacting with the genetic material of the tumour, the DNA of the tumour. And when it interacts with DNA in the tumour, but also with DNA in normal tissues. But the thing about tumours is that they have defective DNA repair mechanisms. So we give a small dose each day. Typically, a course of treatment might be 6 weeks of daily treatment, Monday to Friday. 30 treatments would be fairly typical. And each day when that treatment's given, the DNA in the normal tissue is damaged, but it repairs. The DNA in the tumour tissue is damaged, and it usually is much less effective at repairing that. So day by day, as those 30 treatments go by, the tumour loses a little bit of ground, and by the end of the treatment, hopefully the tumour cell has died and the normal tissue has been able to repair. Now, the repair in the normal tissue might not be 100%, there might be some small amount of remaining damage, and that's what's responsible for some of the late side effects of treatment. And the picture on the right is just showing what form that DNA damage takes. So DNA you might have heard of as the double helix. They're two strands which run alongside one another. And if one strand is damaged, it's easier for that to be repaired because the cell's machinery can look at the other strand as to what the code should be. But when both strands are damaged, it's more difficult for that to be repaired, although there are mechanisms that do repair that in normal cells. So also I wanted to say a little bit about why some children need radiotherapy to the whole brain and spine, and some children only need localised radiotherapy. And basically in children, some tumour types, such as for example medulloblastoma, have such a high tendency to send off little seedlings through the fluid that surrounds the brain and the spine that they always need the whole brain and spine treating. So in those children, even if they had a lumbar puncture to take some of that spinal fluid and there were no cells in that, they would still need the whole brain and spine treating because it has such a high propensity to spread. In the very youngest children, under 3 years, we usually try to avoid that, and we might try to control the tumour with chemotherapy, or we might try and use chemotherapy to delay their radiotherapy treatment until they're older. But those approaches do mean that young children have a somewhat lower chance of being cured because the most effective treatment, the radiotherapy, we're having to hold back. There are other tumour types that need craniospinal radiotherapy, so treatment to whole brain and spine only in certain situations. So, for example, ependymoma is a tumour type that might only need localised treatment. But if when we scan the child there is obvious spread to other parts of the brain or spine, or if when we take a sample of fluid there are tumour cells circulating, then we can need to treat the whole brain and spine. It's also important to realise that unlike in many cancers elsewhere in the body, in most cancers elsewhere in the body, once it's spread, it tends to be incurable. But in brain and spinal tumours, even when there is spread, they're still potentially curable. So that's at least a sort of positive note. Also some comments about sort of special consideration of radiotherapy in children, because I mentioned that I treat adults and I treat children, and I find that a very good combination, because while I might only have 20 new children a year, I have about 150 new adults, so I spend all my time doing radiotherapy planning for brain and spinal tumours. But when I plan for children, then there are some special things that I think about. So one is that children are much more vulnerable to decline in their memory and learning. So we go to more extreme efforts, if you like, in children to try and preserve the areas of the brain that we think are most important in memory and learning. And it's partly that they're more vulnerable, but it's also partly that when you're a little 4 or 5-year-old and you haven't yet learnt to read and write, if your memory and learning is damaged at that stage, if it's badly damaged, you might struggle to acquire those skills. Whereas if you're 20 and you've already learnt to read and write, and I now damage your memory, you're not going to lose those skills you've already acquired. It's a short-term memory thing, so you don't lose what you've already learnt. So that's probably one of the major differences in children. Children's pituitary gland is perhaps also more sensitive to radiation. So the pituitary gland is the gland at the front of the brain that produces various hormones. And importantly in children, big difference to adults is obviously they still have growing to do, and that gland secretes growth hormone. And also they've still got to go, the younger children have still got to go through puberty, and that gland secretes the hormones that let them go normally through puberty. So after children have been irradiated, they need to be monitored for those things to make sure that if they become deficient in any of those hormones, that they're supplemented to enable them to progress normally. But obviously, if at all possible, we try and avoid that injury in the first place. And finally, if we treat a young child and they're 5 or 10 at the time of treatment, obviously they have 7 or 8 decades of life ahead of them, so they've got longer to actually develop the side effects of treatment. Okay, I wanted to show you now how radiotherapy is planned, and this shows a child at the Christie having her mask made. She's in the CT scanner and she's having a mask made to hold her still for the radiotherapy treatment. And most children over the age of about 5 are able to do this without general anaesthetic, but younger children might need a general anaesthetic to enable them to be still for treatment. The mask is made out of a material that we put in a warm water bath, and it becomes soft and mouldable, and then it's draped and shaped over the child, and they have to lie there for a few minutes while it sets and hardens. The next stage then is to make some marks on the mask. And those marks are so that we can align the child accurately for treatment. So those marks are lined up with laser lights in the room to make sure the child is accurately positioned for treatment. And a lot of the young children enjoy decorating their mask, and it makes it more personal for them. So once we've got the mask, the child needs to have a CT scan wearing the mask, and we would usually also need an MRI scan, and that might need to be obtained especially for radiotherapy treatment, or we might be able to use one that's already been obtained. My job as the oncologist then is to mark up on the scans what area we need to treat, and to say what dose we need to treat it to, and also to mark what areas we need to avoid entirely or limit the dose to. And again, I need to say what dose levels they need to be kept below. Next, the physicist, or sometimes the planning radiographer, comes in, and it's their job, after I've marked what we need to treat and what we need to avoid, it's their job to plan a beam arrangement that will deliver the dose to the tumour and it will spare those organs. So here, this is a horizontal cut through the brain. So at the front here, a bit lower down would be the eyes, and that's the back of the brain. And I don't know how well it projects, but you might be able to see there's 5 different beams coming in plane there. And here, looking at a sideways view, there's 1 beam coming in out of plane. So there's 6 beams being used to irradiate this tumour. The tumour area that we're trying to treat here is this area at the centre, outlined with the light blue line that you might be able to see. This shows what the treatment plan actually looks like. So again, the light blue line here, this circle, is the area that we're trying to treat. The red dose is the intended dose. In this case, it was a dose called 54 Gray. We're trying to deliver to the tumour. You can see as we move away from the area we're trying to treat, the dose very rapidly drops off, and these more distant areas of the brain are getting quite a low dose. Or again, if you look in a sideways on view, this is the high dose area, and then there's rapid fall off, but there are areas of the brain that get low dose. This would be an example in a child needing the whole brain and spine treating for medulloblastoma. This child had circulating cells in the fluid, so they're in the higher risk category, and they needed a moderate dose to the whole brain and spine, which is shown here in green. But this area, the tumour bed, where the tumour was operated, needs the full treatment dose, and that's showing up there in the red colour as the higher dose. That treatment, the treatment for the child I've just shown you, that's done in 2 phases. So we would have 4 weeks of treatment where we were treating the whole brain and spine, and then we'd have another 2 weeks and a day, another 11 treatments treating just the back of the brain, and that's what we call the boost phase. And this is what the treatment looks like in the boost phase. So it's very precisely shaped around the area that we're needing to treat, where the tumour originally was. This is looking at the boost phase in the horizontal plane again. The eyes would be at the front, and this is the back of the brain. And the reason I included this is I'll show you here that I've outlined the inner ears called the cochlea. And you can see on the right here especially, that inner ear is incredibly close to the area that we're trying to treat. But we go to great lengths to make sure that as much as possible we spare those important structures. So those inner ears lie in a lower dose than the tumour dose to try and best preserve hearing in that child. And this is another view at a different level in the same child, and here I've marked up what's called the hippocampi, which are structures that are thought to be important in memory and learning, and again they're incredibly close to the volume that we're needing to treat, but as much as possible we've tried to get those into a lower dose area to spare memory and learning as best we can. So just to show you now how radiotherapy is delivered, this is a typical radiotherapy treatment machine. The child lies on the couch here, which can move up and down, left and right, in and out of the machine. This is the head of the machine that the radiotherapy comes out of, and that can move in a complete circle around the child so that the beam can be delivered from any direction. This is the same for a proton treatment machine. It's slightly bigger, but the principles are the same. This is the nozzle that the radiation comes out of. This is the couch that can move in different directions. And again, the nozzle can move 360 degrees around the patient. This is a child being positioned for treatment to her brain and spine. So she's in her mask, and you can see here the room laser lights that I mentioned that will be aligned with the lines on the mask to position her. So I'm going to say a few words now quickly about protons, and I'm getting a hint that I need to get on with it. So very quickly, I'm sure there'll be questions if we have time, we may not, about protons. What's different about protons to conventional radiotherapy with photons, as we would give it in the UK? So the main difference really is because of the beam profile. With conventional photon treatment, the highest dose, this is a beam coming in from the left to the right, and this is the depth in tissue in the child, and this is the dose. So with photons, the highest dose is reached just under the skin, and then it decreases at depth. And if this is the depth of the tumour that we're trying to treat, there's some dose here at a more shallow level that we don't need, and there's some dose beyond here that we don't need. With protons, in fact, the skin dose tends to be a bit higher, but there's some dose all the way in. There's then a higher dose at the level of the tumour, but there's no dose beyond. So it can be used to spare some of the tissues beyond the tumour. So I'm going to go fairly quickly here, given my hint, but it's important to say there's no difference in tumour control with protons. It's the same dose to the tumour, and that needs to be the case to get good tumour control. But there may be less dose to other normal tissues, so that can be used potentially to reduce the late side effects of treatment. It's important to say, though, in some cases there may be very little difference, and particularly for children needing the whole brain and spine irradiating, there is very little difference. This is a proton plan on the left and a conventional plan on the right, and it's partly to show you that there can be relatively little difference. Very similar dose to tumour, slightly lower dose here in the blue than the green in the right, but not a dramatically big difference in some cases. In the NHS, you probably know that children and teenagers and young adults are very highly prioritised to go abroad for proton treatment. There is a list of tumour types which they can go abroad for, and really the intention is that every child who would derive significant benefit is funded. That does mean some children don't go, and that may be either because they wouldn't derive significant benefit, and also often because them going abroad would delay their treatment, even by a week or two in some tumour types can reduce their chance of cure. When the UK service opens in summer 2018, it may be that some of those children where delay has been the major issue will become eligible. I'm going to skip over that. And just to say briefly that we're not complacent, we are trying to improve radiotherapy. There's more and more knowledge about different tumour types. Medulloblastoma would be a good example where we're learning about different tumour subtypes, some of which probably in future will have a lower dose, some may have a higher dose. There's been a lot of painstaking research over the years to get to the point where we are now, and there are still ongoing trials, and some of them that you may have heard of ongoing at the moment. There's a trial in germ cell tumours which is open, a trial in ependymoma which is opened in 1 or 2 centres, I think, and will soon be open across the UK, and there's a trial coming very soon in medulloblastoma. These are European international trials, and the aim of them generally is to improve the cure rates, particularly in the ones where the cure rates are low, and in all the children, if possible, to reduce the late side effects of treatment. Thank you.